And get started. Thanks for everybody who's joining here for today's talk, which is entitled Highlights from IAS 2025. This is part of our CIRA International Research Series. And my name is Luke Davis. I'm one of the hosts of today's webinar and one of the faculty members responsible for international programming here at the Center for Interdisciplinary Research on AIDS. We're an HIV research center, which is funded by the National Institutes of Mental Health. And it's nice to see many old friends and other new participants. Today's event is a webinar which is being recorded. Links to recording and slides and handouts will be mailed to all registered attendees so that you can go back over what was covered today. We'll start today's webinar with an introduction to the speakers, and then we'll have four presentations, followed by a moderated discussion and Q&A with audience members. Throughout this webinar, audience members can submit questions or comments with the Q&A feature. And if you have any questions, please look out for that in the Zoom menu. At the end of the webinar, as you leave Zoom, please take a few minutes to fill in our survey. It's very helpful for us in terms of planning our programming, understanding what types of topics you'd like to see in the future, and for providing any feedback on how the events got organized. So before we get started, I'd like to just give a little bit of an overview of the IAS conference. Although I wasn't able to attend, I did follow the activities. And I think it's really a pivotal year for HIV. It was an exciting idea or programming for the event to take place in Kigali, Rwanda. This is at a time where we have incredible scientific breakthroughs, some of the greatest progress we've seen in generations in terms of HIV prevention, but overlapping with a funding crisis that fundamentally threatens to reverse decades of progress in the HIV response. Inevitably, with Rwanda hosting, there was a political dimension as Rwanda tries to highlight its health leadership, which is truly impressive as part of its quest for ever greater hegemony in Africa. But nonetheless, IAS 2025 was pivotal in being held on African soil and highlighting all the accomplishments. The African continent has been leading innovation and progress in getting to our HIV elimination goals. And I think in this time where there's a need to maintain a strong, united, and resilient response to HIV/AIDS, Africa has a great message and offers a strong place to start. One of the important events of the conference was the Kigali Declaration. Many of you may have seen it, even if you weren't present. And I've included a QR code, if you haven't, to check it out, which is really a way for researchers, people living with HIV and other members of the HIV/AIDS research community to stand up for the importance of HIV research and programming. Please add your name there if you have a chance. I'd like now to talk a little bit about what were some of the major conference takeaways. And to this, I'm indebted to the IAS. I've included a link here which goes into more detail. But some of the themes that were highlighted were really, of course, the impact of funding cuts. I know someone had asked ahead of this webinar, was any data presented there? Yes, there was. There were quite a few studies looking at the dramatic impact of the the loss of US funding in particular. There was a study from Mozambique that reported a 25% drop in ART initiation in February 2025 as compared to 2024. And across the board, deep declines in testing of 8.5%, 31% decline in HIV diagnoses, and 30% declines in ART initiation in data coming from Johannesburg. In the Western Hemisphere, the impact was no less severe. In a survey of 40 HIV service organizations in Latin America and the Caribbean, about 87% reported having lost funds, affecting HIV services to over 150,000 people. I think a second big theme of the conference, as I've already alluded to, is Africa at the center of the response, and lots of programming kind of highlighting African leadership in a lot of different areas, including in basic science and vaccine development and outbreak response innovations. Lenacapavir obviously is one of the most exciting technologies or drugs we've seen in a generation. Continue to hear new studies coming out showing that these approaches, long-acting approaches to HIV prevention, including injectable approaches, are far more acceptable to many people in a number of studies that were presented. But one of the challenges that remains is gaining access to these very expensive drugs. Some new agreements between Gilead, the maker of lenacapavir, but really very modest. More exciting is the idea that there are other drugs that are coming along to increase the options for patients and hopefully drive down prices and push pressure on access. So data was presented on MK-8527, which is an exciting oral long-acting regimen. And I think very, very notably, the medicines patent pool and Viv Healthcare announced a licensing agreement, which will allow co-production or generic production of long-acting cabotegravir. I mean, that's going to make the drug available for use in combination with olpiravine in over 133 countries. Kind of rounding out some of the science and progress there, strides and setbacks in pediatric and adolescent care. So there were some exciting results related to digital adherence for ART, but also studies presented showing that structured interruptions allowing adolescents and young adults to hold their ART treatment on the weekend were associated with worse outcomes. You know, again, kind of saying that there's more to be done to develop drugs that are easier for patients to use. Some breakthroughs in broadly neutralizing antibodies. I think this is exciting because it gives an additional tool in the armamentarium for thinking about how to prevent vertical transmission of HIV from mothers to children, but also it's an exciting tool for even basic and translational research to better understand how we can get to HIV cure, and a lot of fundamental science presented there using broadly neutralizing antibodies. And then finally, technology continues to be an important theme. That's actually one of the areas that CIRA is very interested in, along with some of the long-acting regimens, and lots presented on artificial intelligence, chatbots, blockchain even. So we're in an exciting era, even though the funding cuts are quite concerning. So with that, I'd like to now introduce our presenters, who we're really delighted to welcome today. In view of time, I won't give full introductions. Their bios are going to be pasted into the chat. Thank you, Denny, for doing that. But our first speaker, I believe, will be Alexandra Deac from the University of East London. She's one of our panelists, Yulia Rozanova. We're also fortunate from the Yale School of Medicine. We're also very fortunate to be joined by a Yale alum and now faculty member at Boston College, Katie Sileo. And then our own Donna Spiegelman from CIRA and also the Center of Methods and Implementation of Prevention Sciences is going here at Yale, is going to also be speaking. So thank you so much to our panelists for joining. I'm going to stop sharing my slides so that we can share the slides with the presenters.
Thank you. I think I'm the first one to present, so I'm going to share my slides. That's okay. Dini, do let me know in case it doesn't work. But I hope you can see my slides. Can you see my slides?
It's not full screen yet.
Okay, let's try now. Can you see my slides?
Mm-hmm. Yes.
Perfect.
Thank you, Alexandra.
No, thank you. So, hello, good morning, good afternoon, and good evening. Oh, sorry. My name is Alexandra Deac. I'm a researcher at the University of East London at the Institute for Connected Communities. And I've been working closely with Dr. Rozanova and colleagues since 2022. Today, I'm going to present about a meaningful topic to me. And this is meaningful for me both as a professional and as a personal witness, as I've witnessed up close the impact of addiction and incarceration. And I'm more than happy to share today our abstract from IAS, and I'm going to share some reflections from key sessions that I have attended. So just to give you a bit of a background, in Kirk's prisons, HIV prevalence remains over 10%, and about 3/4 of incarcerated individuals have a history of injecting drug use. Opioid agonist therapy, or OAT, is highly effective in preventing HIV transmission, but uptake remains low in psych prisons. So our main focus within this pilot was whether a co-produced psychosocial intervention can improve mental health, resilience, and readiness for OAT as a pathway to HIV prevention. We piloted and developed HOPE, which stands for Help OAT Prison Engagement, in 2 Kirk's prisons with 2 comparison prisons. It consisted of twice-weekly group psychoeducational sessions over 6 weeks, blending clinical and psychological input with peer expertise. We surveyed 98 HIV-negative participants with an IDU history, but not on OAT at baseline, and follow-ups for up to 12 months. And here on the right of my screen, you can see a video that was filmed during halfway, so during the transition between prison and community. And I'm gonna briefly share my screen. Hopefully you can see the video.
Итак, мы говорим, что
So the sessions were delivered in Russian, and you can see here both attendees, but also the materials that we used during the sessions. And what we found was actually very important. First, hope increased life satisfaction. So we had around 6 points increase at 12 months follow-up in hope group. Depression levels dropped in hope group by 6.5 at 12 months follow-up, and resilience actually increased by 3.5 points. When we conducted in-depth analysis, we found that predictors of improved mental health were hope participation, colony type, and having children. And this demonstrates that the environment matters, and also social support matters as well. And family connections can actually boost well-being. What's really important is actually to highlight the trend that OAT uptake actually increased in hope participants by 11.5% compared to 2.3% in the control group. While this was not statistically significant because this was a small sample, it shows a promising trend. But what I want to also highlight is why it matters. Well, prisons are critical HIV prevention slides. When we conducted HOPE, we saw that psychosocial empowerment can actually strengthen OAT engagement, improve resilience and well-being, which actually closes key gaps in HIV prevention in such settings. And although OAT prevents HIV, its uptake is quite low, especially in prison settings, and this is due to compounding barriers such as stigma, criminalization, and lack of psychosocial support. We also conducted pre and post expert consultations with people with lived experience, and we actually found that people in prison present interventions that conspicuously single out drug users and prefer interventions that target overall mental health with addiction element, and HIV reduction being a discrete part of it. I want now to just take your attention and highlight some of the key takeaways from 2 key sessions that I attended. And the first one was focusing on mental health in the HIV response. And Amanda Miller said that mental health is a key part of the HIV prevention puzzle, while Lydia Efobi added that for good science, we must understand the human side. Speakers highlighted that poor mental health increases engagement in risky behaviors, including drug injection and unsafe sex, which drives HIV transmission. Depression and suicidal ideation are strongly linked to higher risk behaviors. And we've seen that in other projects in Europe, such as the CC driver. What I want also to emphasize is the second session that I also attended, and that focused on the power of prevention. And I will start by reading the quote from Michael Reid. An act of kindness, a helping hand, reaching out, empowering individuals to regain their voices. One person uplifted becomes a beacon for others, a catalyst for change, impacting broad communities. That is the power of prevention as a butterfly. Helping one person is not a drop in the ocean, it's the beginning of a wave. And I found this so powerful, both for providing an illustration of what HIV prevention means, but also on the emphasis that if your efforts, be that as a friend, be that as a clinician, be that as a researcher, have changed the life of a person, that makes a huge impact. These butterfly effects remind us that prevention starts with the individual. When one person is supported, the experience can rip outward to influence peers, families, and entire communities. I don't know why it does that. another key takeaway from this specific session was that access to prevention is not guaranteed. And while this is true for various communities, people in prison are particularly disadvantaged, as prevention can slip into second place, especially when facing key barriers, as I've mentioned earlier. Any person who wants or needs PrEP or to start OAT need or should have access to services. Psychosocial interventions such as HOPE can empower people with the necessary tools and knowledge to support prevention efforts, complementing and supplementing the biomedical field blind spots, if you'd like. Psychosocial interventions need to address what people want, need to be respectful, and need to address exactly needs on the ground, creating stigma-free services and overcoming structural barriers that prevent access, whether they are cultural, whether those are legal or bureaucratic. And as Mrs. Milanga highlighted, this is the role of advocacy. From other experiences in the UK, including working with HMPPS colleagues and with people with lived experiences, I learned that patient and public involvement needs to take a step further and allow for co-production efforts to be embedded across all stages of research. When working with prison population, indeed things are complicated for various reasons and limitations, but the essence remains and applies: nothing about us without us. And I also highlighted a few questions that I remained post-conference, and I'm not going to read them all. However, I just want to highlight two of them. The first one is what role can decriminalization play in making treatment and prevention possible in prison settings? And the second question that I want to highlight is how can we best integrate the voices of people with lived experience, including people in prisons, into HIV prevention strategies? And to close, I just want to quickly go back to why it matters. And I just want to highlight that every person matters, and we learned that in HOPE. Supporting even one incarcerated person to find resilience and readiness for it is not just an individual achievement. It's a catalyst for community well-being and for public health. And to close my presentation today, and thank you so much for your patience, I just want to thank our HOPE team, and I want to thank Dr. Julia Rozanova for bringing hope even in hopeless settings. Thank you so much.
Luke, am I next?
Great. So yes, now we'd like to invite Julia Rozanova to speak.
All right, so let me try to share my screen. Sorry, just 1 second, because I'm grappling with the... There it is. All right, well, Alexandra has set such a high bar for the highlights. Mine will be much more modest, but at least I get the kudos for bringing a wonderful team member to this webinar. So thank you so much, Alexandra. And I am so thrilled that the preliminary data that we gathered during the HOPE pilot was deemed indeed important by NIDA, and we got funded for an R01 just 3 weeks ago. So we will continue to bring hope, I hope, and you know, help to save lives one at a time. So here is also my disclosure, no conflicts that I can report, and this is the team in Ukraine. So I'm going to be talking about the abstracts that we presented or that were presented where I was the senior author from the Ukrainian side of our enterprise. So that's our team in Kiev when we still could be together there. And hopefully one day we will be able to do that again. So this is the work of Irina Piccola and her colleagues, and it comes as the description of the adaptation that we have been making of the decision aid for HIV status disclosure for older adults in Ukraine. And we were focusing here on learning how to co-produce with older people with HIV a culturally acceptable decision aid tool for HIV status disclosure. The project and the disclosure decision aid is called Porada, which is an abbreviation. It's a word in Ukrainian which means advice, but the abbreviation can be deciphered as pursuing optimal results over aging via decision aid. So the idea of the decision aid for disclosure is not at all to increase more disclosures, because it's very possible that for a lot of people, the best thing that they can do is keep their mouth shut about their HIV. And the decision aid is supposed to help them make the best informed decision that they will not regret going forward, that will maximize their likelihood of a positive reaction if in case they disclose, and minimize negative and stigmatizing reactions, so that in some cases, to minimize those reactions, they should not disclose. So this particular abstract was presented as a poster, and I will show you the poster in just a second. So what we learned is that the process of co-production of the decision aid with older people with HIV was a lot of fun. It was very hard work, but also it was like really exciting, because we had, great like conflict resolution where people had different opinions about things, and they really confronted researchers and said, no way, this is like a really dumb language to include into a brochure like that. And then we also had input from HIV physicians in Ukraine, from social workers, and from psychologists, all of whom are participating in the context of providing care, and with whom older people with HIV are talking out their questions regarding disclosure, or sometimes inadvertent disclosure of their HIV status to other people. So we have incorporated qualitative findings from about like almost 10 years of our previous work in Ukraine, where we had interviews and focus group discussions, and we had different kinds of quotes. And then we had some focus groups specifically about HIV status disclosure with older people with HIV and their caregivers, as well as their clinicians. And so the quotes were used to kind of, make the brochure live, like make it really vibrant. So then we have produced this brochure, which was a paper-based tool. It's like a little booklet. And then we piloted that through working with older people with HIV who were consultants to assess the feasibility and acceptability to other older people with HIV. And so the tool has different sections where a reader is guided through systematically weighing the pros and cons of disclosure. There are also some targeted and guided exercises for planning disclosure, preparing for those conversations, providing some real-life examples tailored to Ukrainian experience of older people with HIV, and then it gives some techniques and tips for addressing challenges such as stigma and for how to build networks. And then in parallel to that product-facing patients, we also had a consultant guide that was developed for implementation by either social workers or by older people with HIV who would be peers to people like themselves. So why we think it's important? Well, first of all, because co-production is important in giving the right voice and the right language to the tool and making it culturally sensitive. So one big example was that status disclosure is a very neutral thing in English, or at least so we assume. But when we had this included in the brochure, like right on the first page, and Ukrainian older adults with HIV saw it on the table at the focus group setting, they said, we're not going to even touch this shit, excuse my French. This is no okay, it's something that is just offensive. And language like that, you know, like you assume that I have something to disclose, first of all, and you assume that disclosing is a good thing. And then it's like, just don't even use those kinds of words. And so we were shocked, to be quite honest, because we never thought that it was really, well, you know, like a problem. And we never thought that that kind of language would be concerning, because we went to great lengths to describe that you're not supposed to be forced, you know, to disclose. It's not something that is mandatory. It's just a tool for you to think about it in your best interest, because you may want to not disclose and just want to reinforce that view. But even the suggestion that disclosure is somewhere on the horizon is really not good, you know, for readers, for this audience. So we made amends, and in the language in the final book, we cleaned it up. And we used the various other ways to talk about that. And it kind of went along the same ways that Alexandra described for hope, where we just use general language, like, you know, improve your health. Good for everybody. Everybody agrees. Good goal. So, you know, stuff like that. But this is important because, you know, we learned that the audience knows best what's good for them. And in this context, you have to listen to them, and you really have to go with their suggestions. And it's very empowering for people to, you know, to be heard, and then they rise to the occasion and they really improve the tool. So this is the poster, and you can see here, it's very small, unfortunately, but this is how, like on the right-hand side, how this decision aid tool looked like. And we also worked with our consultants, older people in Ukraine with HIV, how to make those little cartoon characters so that they had the right profile color, you know, sort of features that would be quite right for that audience and would be, you know, encountered positively. So now some highlights for me from the conference, and I, similarly to Luke, I wasn't there, unfortunately, so I was only able to join virtually, and also off time, because, you know, a lot of times I was not doing sessions live. I was doing it when they were already recorded, and that kind of was a very interesting experience in and of itself, both wonderful and really sad, because you know that it's already over, but you are kind of reliving that moment. So it's just interesting for me, because I've never done it like that before, you know, off time. So I was quite struck by the Getting to Grips with Prevention plenary, and the things that were discussed about the vaccine discovery and the research that continues, about the evidence-based innovations to simplify and demedicalize PrEP choices, barriers that have not yet allowed to reach triple elimination of HIV transmission from mother to child, but also the transmission of syphilis and hepatitis B. And as I was attending those talks, my philosophical question was, does this work on prevention help or hinder finding HIV cure? So my work does focus on HIV prevention, a lot of it does. And so I was thinking like, okay, so there are a lot of people like me, and we use a ginormous amount of resources. Is it resources well spent when we have very little money now? Is it best to just drop all of that stuff and really focus on finding HIV cure? And, you know, kind of like very significantly shrink all that work about prevention, because, you know, I mean, you can package PrEP in all kinds of myriad ways. It costs a lot of money to test out which is the best way to package, and rolling out this peer intervention or that, or, you know, the next thing. It's a lot of resources. Like, is it the best way for us as humanity to approach that? And I don't know. I mean, you know, like part of me says, of course, we have to work on prevention, and prevention is the best treatment. But part of me is thinking like, we haven't really cured it, you know? And, you know, like in the society which created AI and all kinds of other advances and so many killing machines, how is it possible that we haven't really cracked that nut? So then I also was really interested in the Rethinking Approaches to Clinical Studies symposium by where Donna Spiegelman led the way. And I will, you know, look forward to hearing her presentation, because I was going to cover it, but then I realized that it's best left to her. But some other general takeaways for me from the conference were related to just how to navigate this, environment that has become resource poor for everybody, including high-income countries, and how learning from low and middle-income countries has become very, very crucial. And then, the immediate response to this emergency versus long-term. So the message that I heard was resilience. Let's just keep fighting, saving one person at a time. But this was just, no cure. Again, that was just like, keep standing until you die, essentially. Well, is it good enough, So the sort of concern that I had, and it did not help me to alleviate this concern, is that we don't know how to withstand those enormous pressures. We'll just have to see how it pans out. Now, two other
Julia,
things.
so sorry to interrupt you. I wonder if you could just maybe wrap up so that we have
Okay, yeah, of
from
course.
Katie and Donna. We're a little short on time. Thank you.
Sure, of course. Sorry. So one thing that stuck with me, and I mean to kind of observe and pursue it more, pay attention, is rise of non-communicable diseases and the need for holistic response. And that is both true in terms of just like how HIV research is going, but also in this context of few resources, because I heard it, in different talks that HIV is still sort of like provided for free, but non-communicable diseases are not supported by insurance in many places. And so people just are not treating them. And that creates a huge problem. And then the last thing is digital format of the conference, but also the AI. It wasn't as sort of like discussed as much at the IAS as it was at the ISA that I attended just before that conference, the International Sociological Association. And so AI was just number one, probably the only topic there. Like, what's going to happen with this whole digital thing? Can we protect ourselves against it? What are the dangers? And I think that that conference also shows it, to me at least, that it's great, but at the same time, I could not experience being together with people. And so, I'm sure that my understanding of these ideas could have been different had I been there in present at the conference. So I will stop here, and thank you so much, and sorry for being over time, Luke.
Thank you, Julia. That was wonderful. So now we'll introduce Katie.
Okay, excellent. Let me share my screen. Okay, is that looking how it should?
Can you swap monitors?
Monitors, sure.
Thank you.
How's that?
Perfect.
Okay, excellent, great. Okay, well, thank you for this invitation. I'm really excited. It's very exciting to be presenting along these other very excellent presenters. I'm Katie Sileo, and I don't have any conflicts to disclose. I want to share that the research I'm presenting was funded by an NIMH Career Development Award, and my co-authors are listed here, which includes collaboration with the Makerere University School of Public Health in Uganda, folks at Yale and at CIRA, and other folks that have contributed to this work in a very significant ways. Okay, so the abstract I'm presenting is titled Men Behave Like Babies, the Role of Gender Norms in Shaping Relationships Between HIV Care Providers and Men Living with HIV in Uganda. This work is based on global calls to improve HIV programming efforts to better engage men in HIV care and HIV prevention based on evidence of men's worse engagement in care across the continuum globally and including in sub-Saharan Africa. So much work has been done to understand how gender norms shape men's HIV-related behaviors. For example, how masculine norms of toughness might prevent men from seeking care or asking for help until advanced disease stages. But there's been less work that has looked at health system drivers of men's engagement in HIV care. And so our research questions in this abstract are to explore how HIV care providers perceive men as clients and how their treatment of men is shaped by gender norms, with the goal of ultimately developing interventions to improve men's care engagement. The study was qualitative, and it included focus groups with HIV care providers, as well as men and women living with HIV and receiving HIV care at public health facilities in Uganda. So just a snapshot of these results. We organized the findings using 3 overlapping domains for patient-centered care, which you can see in the figure. It was informed by 2 related conceptual frameworks for patient-centeredness, which are listed in the notes there. The 3 domains are biopsychosocial perspective, decision-making processes, and features of care, including things like respect, trust, and empathy. The domains are closely related. Gender norms shape experiences in each of them. And I think challenges in one domain often spill over into the other, as you'll, I think, see in the findings. So first, for the biopsychosocial perspective, we found that many providers viewed men as disengaged or non-compliant based on their experience with them. But men themselves describe structural and social barriers like work demands and HIV stigma as their key reasons for delayed care or poor engagement. However, men's poor engagement was interpreted by providers as disinterest and irresponsibility, especially compared to women who were kind of considered good clients. And this perspective shaped how providers approached interactions with men, which connects to the next domains. Within the decision-making processes, men were frequently described as impatient or rude during clinic visits. As one provider said, for the majority of men, they are impatient and cruel when they receive services. Men's directness partially reflects their learned gendered communication style to be more direct culturally. But in this context, it also stems from time constraints, fear of stigma, learned emotional stoicism, and sort of their masculinity or gender-related barriers to care. We also found that gender power dynamics were at play here. Women providers in particular viewed men's communication as rude and said that that men often challenged their authority and had trouble taking direction from them, particularly for young women providers. So these communication and power dynamics are shaped by gender norms, and together, I think they influence levels of trust and empathy between providers and men living with HIV, which is highlighted in the next domain. So we found men place a very high value on being treated with respect, a reflection of masculine norms tied to dignity and status. As one man in the quote here describes, when men are dismissed or reprimanded at the clinic, it's imprinted in them that there's no help at the facility. So unfortunately, I think because of these gender dynamics at play, providers, especially women, seem to often struggle to empathize with men's barriers to care. And this dynamic seems to limit the ability to build trust within relationships, which seem to go both ways, both trust in men among providers and trust in providers among men. So I think these are important findings because they illustrate how men present to care is shaped by gender norms, including their gender-related barriers to care, their gendered communication style, their openness to receiving instruction from providers, and sort of power dynamics at play there that relate to gender. And these dynamics shape providers' perceptions of men and their treatment of men. In this setting, I think the dynamics can negatively impact women providers' perceptions and empathy towards men in particular, and that could in turn worsen men's care engagement as it's likely to impact providers' treatment of men. So I think there's a need for HIV programs that consider these dynamics in tailoring HIV services to better engage men. And I think that can be accomplished in many ways. One way is training providers and sensitizing them to men's barriers to care through a gender norms lens, as well as their ability to provide kind of client-centered care in general that is inclusive of gender norms and manage gendered power dynamics that are at play. Based on these findings, our team did that. We created a gender sensitivity training for HIV care providers, this work fed into that, which was found feasible and acceptable in a pilot trial with promise at changing relevant outcomes. And so if you follow the QR code, and that will link you to one of our publications if you want to read more about that. So I'll keep it brief. I was also a virtual attendee of IAS, which, I felt glad to be able to kind of learn through that platform. But I think, just as Julia expressed, you kind of miss out on the energy and the connections, which is, I think, one of the greatest parts of these things. But for me, I think naturally seeing the gender transformative approaches taken to HIV care and HIV prevention were most exciting for my line of work. And those are programs that try to change gender inequitable norms and address underlying gender-related drivers of the epidemic. And so there were many promising examples of interventions and IAS approaches that we're doing that and showing really, really promising results in engaging men in HIV testing and retention and care and different outcomes. So I have different examples listed here that are specific to sub-Saharan Africa, achieving this through things like male champions, structural changes to the clinic to make the clinics more male-friendly, peer-led approaches to engaging men and young boys were all quite exciting. I think in the light of funding cuts, my worry is a lot of the differentiated care services are getting actually pulled back, and it's like, okay, we still have treatment, but all the things we know we need to engage people are kind of the first to go. And so I'm hoping, that using the strong evidence base we have of what works in IS, we can kind of continue to prioritize the different services that we know are really necessary in addition to just free treatment. Okay, and that's it for me. Thanks so much.
Thank you so much, Katie. That was tremendous. And I'll now welcome Professor Donna Spiegelman to share her IAS abstract.
Hi, everybody. Thank you. Let me, okay, so my screen is shared now, is that right, Deanie? Or do I need to do something to make that happen?
We cannot see your slides at the moment.
I know, so let me share my screen, okay. Let me find it. I'll be ready in 1 second. Okay, here we are. And let me just edit to slideshow. Okay, from beginning. Okay. So first I want to thank the other speakers, both for their presentations and also for their very interesting comments about their takeaways, which I hope I'll have a little time to say a little bit about as well, because I have some agreement about some of them, and some of them I had a different impression. So it would be great to have another discussion about this maybe. So I was present in person at IES for the entire time. And I really enjoyed being there. It was a great pleasure. So now, let's see, I'm not able to move to the next slide. Why is that? Okay, there we go. Oh, these aren't the slides. I'm sorry. I thought I had, excuse me, but this is not the slides I want to use. These are different slides. Okay, here it is. Sorry, everybody. Okay, let me go back to the beginning. So, okay, try again. My session was rethinking approaches to clinical studies, and here is the roster of presenters and individuals in the topics. And as we know from today's program, excuse me, my talk was on innovative study designs, the Learn as You Go clinical trial model. And I had hoped to actually present 3 adaptive clinical trial designs that I think are relevant to HIV implementation research, in addition to the LAGO design, which was developed by our group here at Yale, along with others at Boston University, Harvard, Hebrew University, Tel Aviv University in Israel, and others. There are two other relevant designs, the most design and the smart design. But I'm not going to have time to talk about the most and smart designs today, but maybe another time. And some of them are related in that most and Lago go together very nicely, and smart can also be embedded into Lago. Many of you may have heard these acronyms and some not, and I'm sorry, I can't really explain what they are except for Lago. So in the Lago or Learn as you go design, how it's developed, it was developed to optimize multi-component, multi-level implementation implementation packages or implementation strategy bundles, or even a combination of implementation component packages and implementation strategy bundles. And as we can see even from some of the other talks, in implementation research and HIV prevention, as well as HIV care, it's not a single bullet. We can't just give one thing and expect to solve the problem. Even if, say, we have the PrEP pills or the PrEP injection, it's not as simple as that. We have to screen people, make sure they're negative. We have to initiate them. We have to ensure compliance. We have to have the materials at the facilities or however the drugs are being delivered. And all of these different steps and aspects are essential for making sure that we have high PrEP adherence and a low community viral load to both preserve the health of HIV negatives who are at high risk, as well as people who are already HIV positive. So when we develop these packages and bundles, the typical design is that we set the combination at the beginning of a study at a certain, both the composition of it as well as the doses of it, and then they're fixed. That's the standard clinical trial design. And no matter what we see, say in terms of interim analysis with the DSMB, or even investigators having a feeling maybe things aren't working so well, the traditional design and methods have required that we can't make any change. So what Lago, the breakthrough that Lago has brought to all of this is now we can change. So that's what we mean by learn as you go. And the idea is that we have a certain package and we start it at the start of the study. And then after a predetermined amount of time, we have a Lago optimization analysis where we use all the data, the outcome data, as well as not just what the doses of the components were intended to be, but also what actually happened. And then we recommend a new optimal package for the next period of time. And then we can do that again and reanalyze the data to get a sense of what the package should be. And then we recommend the new package for the next period of time. And how do we come up with this recommendation? Well, we try to optimize it we can optimize it for multiple things simultaneously. And the most common ones, and the ones that we've done so far, are we want to optimize it to, say, achieve a certain pre-specified outcome goal, such as 80% of HIV high risk persons at high risk for HIV are initiated, say 80%, or it might be 80% adherence, say as measured by blood tenofovir levels, or it could be 90% hypertension control. So we'll have that sort of a goal. We may also have a simultaneous goal of ensuring that we have the pre-specified statistical power, say 80%, to reject the null if it isn't true, and that the package, as it's experienced over the course of the study, say doing the standard intent to treat analysis, will still have that 80% power at least, with the standard 5% error rate, meaning that we would reject the null only 5% of the time or less if the null is true. So we guarantee that type 1 error rate, which is kind of shocking for people because the thought had always been that if we start fiddling with the intervention after this trial starts, we'll compromise our type 1 error rate. Well, we've proven in this paper in the Annals of Statistics, which is probably the most sort of rigorous, highest quality mathematical statistics journal that we have kind of globally, that doing this procedure, it's not the case and will still guarantee the type 1 error rate. And then finally, we're optimizing for cost, because actually when you have a complex package like this with multiple components, there are often many combinations of the components that will achieve the goals of, say, the 80% coverage rate, the 80% power. But then to find the very best, we also want to find the one that minimizes the cost. So we work very closely with health economists to determine the unit costs of the interventions. So to make this a little clearer, I'm going to illustrate it by an example. And this is based on a study that's led by Laron Nelson of the nursing school and the School of Public Health, HPTN 096, getting to zero among highest HIV incidence men who have sex with men in the American South. And so here are a whole bunch of package components that they're looking at to improve the prescription rates of PrEP from 18% to 43%. And that would give us a overall odds ratio for the total package to be 2.2. So it's a more than doubling of the prescription rate. And so the ideas are, there's a whole bunch of different package components here that involve health access coalition activities, social media activities, training staff in facilities where people might go to get their PrEP, on autonomous and empathetic support, launching the intervention, and then encouraging peer support. And then, as you can see, there'll be a bound, because it's not unlimited. In many cases, like technically or kind of feasibility wise, we can't expect an infinite number of these. So for example, for the proportion of eligible staff who participate in training, that's 1%. So it's limited by 0.1, and the uptake goal is 75%. And then you can see that we need to do costing still to figure out what the cost of all these components are. So Laron and his team have a certain goal that they're hoping when they launch HPTN 096. And here's the doses of each one of those interventions, and we'll be measuring them either overall or in a sample. And then in the first LAGO optimization phase, we'll see what actually happened, and then we'll see which ones are having the biggest impact for the least cost, and then we'll recommend a new package in which these numbers will probably be shuffled and sorted quite a bit. So here's another example. This is from a study that we're actively working on here at Yale, along with colleagues at the IDRC in Kampala, Uganda. It's called PALISA, and Fred Semitela and Chris Longnecker of the University of Washington are the MPIs, and Jeremy Schwartz is the site PI here at Yale. And what we're trying to do here, and I think this was mentioned by one of our other speakers, is looking at the integration of NCD care, specifically hypertension care, into large public HIV clinics in and around Kampala, Uganda. And so what we're trying to do is increase the supply of antihypertensive drugs dispensed to hypertensive patients. And then what I have in these two columns here is the actual estimated effects of this from the data in terms of increasing hypertension control among, in this first column, all patients, and then in the second column, hypertensive patients. And then here we have access to blood pressure machines, and then from that we look at the number of visits at which blood pressure is measured per patient. And we can see that has a big impact among all patients in increasing hypertension control, a relative risk or an odds ratio of 2.5. I mean, everybody in 1.5 in hypertensive patients. Then we're training eligible providers, and that's having a smaller impact, but still an impact on improving hypertension control. As you can see here, what we're finding so far is differentiated service delivery, specifically multi-month prescriptions for antihypertensive drugs, is not showing to be effective, with even a relative risk in the wrong direction and significant among all patients, and a 5% non-significant improvement among hypertensive patients. Community delivery, it's a little mixed. It seems to not be productive among all patients, but is improving hypertension control among the hypertensive patients. Remote blood pressure monitoring was looked at by screening in the community as opposed to the facilities, not showing a big impact. And then doing performance improvements seems to be quite among the eligible providers. Seems to be working very well. Luke has his hand up, so let's see what Luke wants to say. Luke, how
Okay.
about you just say it?
Yeah, if you could just finish up in the next minute or so, because we want
Okay.
to make sure that we can say goodbye to everybody before the hour comes.
Okay, so here's the estimated cost for these different components. And then here is the recommended intervention package based on the stage 1 data, the recommended doses. So it's saying increase access to antihypertensive medicines by giving even a 2.5 supply to each patient. It's saying measure everybody, screen everybody. It's saying 3.5 hours of training is optimal. And this is what actually happened here, and so on. So I have to go very quickly. And I did want to say that a little bit about CMIPS, our center, and that we're very well equipped to collaborate with people who are interested in using LAGO, MOST, and SMART in their studies, should they wish to do that. And then the last thing I wanted to say about my IAS takeaways was I didn't go to the sociological conference before IAS, but I was really blown away by how the intense and pervasive interest in AI throughout the entire conference. That's my one takeaway. And I feel like in my work going forward, we just absolutely need to be thinking about how to incorporate AI in our work, even from the practical level. If we want to get funded, I can't even imagine that a grant is going to get funded that doesn't include AI in some way. And the other thing, kind of maybe in contrast to some of what Luke was saying, is I was really kind of blown away by the attitude, both privately and sort of, networking conversations as well as on the podiums by our African colleagues about how nonplussed they were by these lack of funding. There was very little hand-wringing, anger, sadness, rage being expressed, as I saw from our African colleagues. Almost universally, and the attitude was, okay, no more funding. We're going to continue to take care of our patients. And basically the idea is we're integrating HIV care into our primary care clinics. And it started yesterday. End of story. So that's what I took home. Other people may have felt differently about this, but it seemed to me that, what we might want to think about in terms of supporting our African colleagues is, how to strengthen the integration of HIV care into primary care, as opposed to even what PALISA is doing, which is integrating NCD care into the HIV clinics. And I got the impression that countries are already just making their HIV clinics primary care clinics. So that's what I saw.
Thank
And
you
I
so
guess
much.
I have to
I'm gonna-
stop. Thank you, everybody.
I'm going to stop you there, but thank you so much for sharing those reflections as someone who attended the conference. And I really want to thank all of our presenters. You guys are all doing very important work, I think, in a variety of areas. And I learned a lot about hopefully how we can find ways to collaborate and ways to learn from you. I'm sorry that we didn't have time for more discussion and questions, but the content was fantastic. We'll be sharing the slides with the permission of the presenters and a recording after this, as well as some takeaways and infographics. So thanks very much, everyone, for your work. Please complete the survey that will come up on your screen as we end the call. And we look forward to seeing you again at a future CIRA webinar.
Thank you very much,
Thanks,
everyone.
everybody.
Thank
Thank you
you.
so much.
Really nice being here with you all.